for that.
Alright,
Oh yeah,
So-
he's gotta say some official things.
Yes.
Just a
yeah,
second.
officially, 9 AM, February 11th, we're going to begin this work session of Lake County Board of County Commissioners.
Fantastic.
Take it away.
So my introduction, you all know me. I'm a physician here in town. I came in 1998. At 27 years now, I guess, is how long I've been here. And since that time, with the exception of 1 year, I have been the medical advisor for the Public Health Department. What that means is that the Public Health Department uses my licensure to do their vaccine for children's program. So they use my license to order vaccines. Under their private vaccine program, I also they use my licensure as well. So it's not that I'm supervising the program because they do such a fantastic job, I don't have to. But it's my medical license that's responsible for all of that. Any of the protocols that the nurses there use or the med techs use are also signed off by me. So when patients come in and they need services that the Public Health Department provides, again, it's all under my licensure. And again, the supervisory role that I've had to do is so small over the past several years, just because they do such a fantastic job. That's kind of my responsibility for the Public Health Department. I'm also available for public health crises. You all remember my videos during the COVID crisis that we did at once a week. But that's also my job, is to kind of help coordinate the public access to the Public Health Department and other medical services when they need a direction here in Lake County. For that role, I have volunteered my services for 27 years. My very small salary is donated back into the Public Health Department for operating expenses. And again, it's very, very small. I don't remember what it is. I don't think it matters. But I do that for a couple reasons. One is my gift to Leadville, and of course I'm a big believer in public health and I want to do that. And two, it helps the budget bottom line to make sure that there are enough resources to be able to, to provide the services that they need. So that's one of my hats. My other hat is your landlord. I own the building that the Public Health Department and Health and Human Services and a variety of other public departments use. I know that you had asked about rent versus ownership. Jeff and I are ready to discuss that whenever you are. So if you would like to buy the building, by all means. You've certainly invested enough in it that it should become yours.
Take it right on.
Yeah, there's lots of things, so whenever you're ready to have that conversation, certainly let me know. But that would not change my role, I would still help with, the development. Jeff and I are thinking about retiring. It's really difficult to leave this place, I love it so much. And I'm having such a great time in my new private practice that it would be difficult, but eventually we all get old and need to leave. So that may or may not happen sooner than later, but. As your landlord, I am responsible for your building. We do have a very detailed contract that Chris put together for us that talk about financial responsibilities, but that's part of our relationship. The other thing that I do is I contract with some of your agencies, the Sheriff's Department. We actually may be the only county agency that I contract with, but I provide medical services. So the sheriff, for example, if someone comes in that they arrest, they have the proverbial bag of medicines, and the patients or the person who's been arrested keeps saying, "Oh, I have to take all of these medications; they're vitally important." I am on call for you 24/7, where the officer can call me and say, "Hey, what do I do with this?" Obviously, if it's an emergency, they're taken to the emergency room, and the emergency room physician interfaces with me for follow-up and those kinds of things. But I am the on-call medical person for the Sheriff's Department if they need something, and you pay me a fee for that. I get paid for being on call for you. Great. And then my other job, we all have like 12 jobs here, don't we? My other job is the hospitalist at St. Vincent's. So when you need to be admitted to the hospital, I take care of that, and I'm kind of used as a liaison for Andy, just because he's a newbie and sometimes needs a little help with that.
I didn't realize you're still doing that. Is that for your patients that need to be admitted, or that's for any of theirs?
I take all comers. Oh, and then I forgot my other job. I do have a private practice. So I continue to take care of the folks at Leadville. And I am the safety net provider here in town. And so what I do is I charge a small fee once a month for people who don't have health insurance, people who are underinsured. I do a lot of free care for folks, and if they can't access. And so I've published my number. It's available to the public. And if you need something, you can come in and I can take care of you. Everything we do in my office is covered by a monthly fee.
So cool, Lisa.
Yeah, no, it's, this town's been very amazing to me, and I feel very fortunate to be able to give back in the ways that I do. We take care of one another, it's what we do.
And then as part of our Board of Health, she's also on our Board of Health as our medical officer,
Right, but
which is kind of an extension.
I do not vote.
No,
Great, I'm not a vote, I'm not a voting member.
Great.
Cool, so I just wanted to, thanks for letting me do that in 7 minutes.
Good job.
Yes, the hospital's exploded, there are thousands of patients that I need to take care of. But I just want, influenza's not kind, as we all know. But I just wanted to make sure that you all knew what I did, that you all had my contact information. So if no one else is online, it's just us. Do you want my cell phone numbers?
Sure.
Tell me when you're ready. It's 719-239-1805. And I provide that for folks because I've been around here for so long. I have a great institutional knowledge of the health needs of the community. And so you're sitting at your desk and you're looking at something and you just have a medical question, I'm at your leisure.
Is this being recorded and put on YouTube?
This is being recorded and put wherever we put it.
Okay.
Yeah,
Oh, so that's, yeah. Sorry.
everyone has it anyway. But that's, that's the number that you use to get hold of me. And if I'm with a patient, I don't answer the phone, but you can text me anytime and I'm available. Yeah. I'm also trying to be creative with the Summit Community Care Clinic and figure out how I can support them. They have a paucity of providers. They don't have enough medical people, and there is no way to get obstetrical prenatal care here in Leadville right now. And I stopped delivering babies about 2 or 3 years ago in the middle of the pandemic where I just couldn't do it anymore. But I'm trying to work with them to see how we might be able to get prenatal care here again, where I can help take care of the folks who can't leave town,
Nice,
because I think that's a big hole in our system.
Absolutely.
for sure.
And they are starting to be with us 3 days a week in
Mhm.
March, okay, great.
Right, and I keep saying, I wanna do a Dr. Lisa free day, with them, and so maybe that's, once a week or once a month or something where I just come in and just, again, take care of all comers, don't expect a salary, and try and be the safety net, provider here again to see if I can get folks in the door who really need medical care. Otherwise, they neglect themselves and they wind up in the emergency room with some horrible disaster, which is totally preventable.
Also be a nice way maybe to get some of your current patient load when you do decide to stop practicing into.
Well, I'm working with a group in Buena Vista who has a delightful young nurse practitioner who's very eager and an amazing businesswoman, and so I'm working with her in an effort so that it doesn't stop.
Nice.
So we'll have the Leadville office and her Buena Vista office, and yeah, I don't think I would just stop. I don't think I can, and that was my big incentive to get Summit Community Care Clinic here, honestly, was that they're reliable, with all the fiasco that happens with the hospital, I'll say that online. Their financial instability was the 4th financial collapse that I've been privy to. I really worked hard to get the Summit Community Care Clinic here so that at least we knew that we would have a reliable stream of primary care. Irrespective of what happened in the hospital, not to say that Andy hasn't done a tremendous job, and here we are in our upswing again, but we've been there before and we've seen this before.
I appreciate that.
Yeah.
That long-term vision.
That's what institutional knowledge will get you.
Grateful.
Yes, old people are valuable. Thank you.
Thank you, Dr. Lisa. Any other questions before we start our
Not for me.
deep dive? Great, thank you so much for
All right,
coming.
thank you again for
Thank
allowing
you,
me to.
Lisa.
Stay
run in and
healthy.
out.
And
Yeah.
safe out there. Okay, so now we're gonna proceed with our Board of Health training. So we've got a number of different trainings that we're gonna do on this CoTrain website, and we'll watch the training together. And write down questions, make a note of questions you have, and after each training, we'll stop and chat. I've given you some resources here that are all part of this public health training that you can look at your leisure, and we can discuss those as well, but we will get started. There we go.
Review and welcome. Welcome from the Colorado Department of Public Health and Environment, CDPHE. Matt Jackson, Interim Director of the Office of Public Health Practice, Planning, and Local Partnerships at CDPHE, provides an overview of this year's annual Board of Health training.
Some nice jams, yeah.
Hi, I'm Matt Jackson, Interim Director of the Office of Public Health Practice Planning and Local Partnerships at the Colorado Department of Public Health and Environment. Welcome to the 2025 Board of Health Training. Our office is not only responsible for providing these annual Board of Health trainings, we also play a liaison role between local health departments and the state health department. A reminder that annual Board of Health trainings for both state and local Board of Health members is a requirement by state statute. We also offer these trainings to provide information to assist you in your role as a Board of Health member serving the communities in your jurisdiction. Thank you for being such an integral part of the public health workforce in advancing the health across Colorado and protecting the places we live, learn, work, and play in your communities and across the state. We look forward to working with you in the future. Thank you very much.
Great, I'm gonna go back. I realized I should be sharing my screen.
Just click OK, it works.
Perfect. Can we still,
You can move that, yeah.
there we go. So many little things everywhere.
And then you can minimize that. Yeah, it's less intrusive.
Great.
Training objectives. After completing the following 2 lessons included in this 2025 Board of Health members statewide training, introduction course, you will be able to discuss the role of a local Board of Health and describe the 6 functions of public health governance. Explain the core public health services and foundational capabilities. Learning objectives for the 2025 Board of Health Training Plan. Provide necessary and helpful information to support Board of Health members in their roles. Meet the state law of providing yearly training to boards of health. Report and provide proof of Board of Health training participation and completion. About the Board of Health members training series. This training series is intended to equip new and existing Colorado local and state Board of Health members with a foundational understanding of public health and provide you with information that is important for supporting your community's local public health agency and leadership. Training for Colorado Boards of Health is mandated by House Bill 211115. This bill added provisions that required annual training for Board of Health members to Colorado Revised Statutes 25-1-508. While there are statutory requirements for being a Board of Health member, most members choose to serve because they care about the health of their community. They care about water safety and clean air and quality of life for all people in their communities. That is why you take the time to learn about the people, the needs and the resources available through the Community Health Assessment, and why you issue orders and adopt rules to protect and preserve public health. It's why learning more and having a deep understanding of public health and the roles of board members is important and valuable. To access referenced state statutes in this series of trainings, please follow the Colorado Revised Statutes link. Then use Go to CRS Online button, then search for the specified statute using the number identified in the training. To fulfill the annual training requirements, all current Board of Health members are sent an annual training plan that will include the following 4 courses. 2025 Board of Health Training Plan. Yearly Introduction. This course includes information for all Board of Health members. Public Health Governance. These training courses cover the functions of public health governance. Select one course, new for 2025 oversight. Emergency Management. Training courses related to emergency preparedness and response. Select one course, newly revised this year, the board's role in emergency preparedness and response. Your feedback. Provide feedback and suggestions for improvements for future trainings in a brief survey. Note, CoTrain will give you the option to rate each course. This rating is optional and is different than the Your Feedback portion of your training plan, which is required to confirm that you have completed the annual training. Certified in Public Health option for state and local Board of Health members. The nationally recognized Certified in Public Health, CPH, credential signifies that a public health professional has extensive public health experience, along with a wide breadth and depth of public health knowledge. New this year, we are offering board members the opportunity to use the CPA to complete annual Board of Health training requirements. At the request of Board of Health members with extensive public health experience and training, Board of Health members with current CPA certification can use the continuing education required for maintaining their credential to meet their annual Board of Health training requirements. Certified in Public Health, CPH, credential. Learn how Board of Health members can attain their CPH by selecting the blue button. Board of Health Advisory Group. The Board of Health Advisory Group provides input on Board of Health training requirements and topics. This group meets quarterly throughout a year and provides insights and input on training content, modalities, and additional resources for board members across the state. We strive for representation throughout Colorado, rural and urban areas, small and large health departments, independent and county commissioner-led boards. If you are a Board of Health member interested in joining the advisory group, please email ophp@state.co. Throughout the Colorado Board of Health Training Plan courses, sections with a light blue background, such as the one below, are optional.
State of Colorado Accessibility Statement. The state of Colorado is committed to providing equitable access to our services to all Coloradans. Our ongoing accessibility effort works towards being in line with the Web Content Accessibility Guidelines, WCAG version 2.2, levels A and AA criteria. These guidelines not only help make web content accessible to users with sensory, cognitive, and mobility disabilities, but ultimately to all users, regardless of ability. This course is part of a meaningful change in making all state of Colorado services inclusive and accessible. We welcome comments on how to improve this course's accessibility for users with disabilities and for requests for accommodations to any state of Colorado services. Please contact us at ophp@state.co.us. JAWS users, when accessing links that take you outside of the course, please select Ctrl plus F4 to return to the course. If you prefer to watch the videos at a faster or slower speed, select the settings icon at the bottom right on the video screen, then select playback speed. Select the CC icon to enable closed captions for any videos or audio content. Alt tags have been included for relevant images. If you would like to listen to the content instead, click the arrows above each section. The audio content is the same as the written content.
This Boards of Health training was developed by the Colorado Department of Public Health and Environment, CDPHE, Office of Public Health Practice, Planning, and Local Partnerships, OPHP. Contact us, ophp@state.co.us. Select the Continue button to move on to the next lesson.
Board of Health roles and the 6 functions of public health governance. Operating as a Board of Health, the National Association of Local Boards of Health, NALBOH, is a national voice for boards that govern health departments and shape public health policy. Driven by by a mission to strengthen and improve public health governance. NALBO works with CDC and other national partners to identify, review, and develop the model of 6 functions of public health governance. The Colorado Board of Health Training Series is structured around these 6 functions of public health governance:
Can you turn it up?
policy development, resource stewardship, legal authority, partner engagement, oversight, and continuous improvement. Policy development and legal authority have been included in past Board of Health training plans. The oversight module is new this year. Resource stewardship, partner engagement, and continuous improvement will be addressed in future modules.
See if that helps at all.
For information about the 6 functions of public health governance, according to the National Association of Local Boards of Health, NALBOH, a Board of Health has responsibility for 6 important functions of public health governance, of which policy is one. Please select the yellow plus sign next to each icon below to access a description of each function. After viewing, select the Continue button to move on to the next lesson.
Partner engagement. Build and strengthen community partnerships through education and engagement to ensure the collaboration of all relevant stakeholders in promoting and protecting the community's health.
These may include, but are not limited to, representing a broad cross-section of the community, leading and fully participating in open, constructive dialogue with a broad cross-section of members of the community regarding public health issues, serving as a strong link between the public health agency, the community, and other stakeholder organizations, and building linkages between the public and partners that can mitigate negative impacts and emphasize positive impacts of current health trends. This is our oversight, assume ultimate responsibility for public health performance in the community by providing necessary leadership and guidance in order to support the public health agency in achieving measurable outcomes. For example, assuming individual responsibility as members of the governing body for actively participating in governing entity activities to fulfill the core functions, evaluating professional competencies and job descriptions of the health director and health officer to ensure that mandates are being met and quality services are being provided for fair compensation, maintaining a good relationship with health director, health officer, in a culture of mutual trust to ensure that public health rules are administered and enforced appropriately, hiring and regularly evaluating the performance of the health director, acting as a go-between for the public health agency and elected officials when appropriate. Exercise legal authority as applicable by law, this is our legal authority, and understand the roles, responsibilities, obligations, and functions of the governing body, health officer, and agency staff. For example, ensuring that the governing body and its agency act ethically within the laws and rules, local, state, and federal, to which it's subject, providing or arranging for the provision of quality core services to the population as mandated by law through the public health agency or other implementing body, engaging in legal counsel when appropriate. Policy development. Lead and contribute to the development of policies that protect, promote, and improve public health while ensuring that the agency and its components remain consistent with the laws and rules to which it is subject. Developing internal and external policies that support public health agency goals and utilize the best available evidence, adopting and ensuring enforcement of regulations that protect the health of the community, developing and regularly updating vision, mission, goals, measurable outcomes, and value statements, setting short and long-term priorities and strategic plans, ensuring that necessary policies exist, new policies are proposed and implemented where needed, and existing policies reflect evidence-based public health practices, and evaluating existing policies on a regular basis to ensure that they are based on the best available evidence for public health practice. Continuous improvement. Routinely evaluate, monitor, and set measurable outcomes for improving community health status in the public health agency's governing body's own ability to meet its responsibilities. Assessing the health status of the community and achievement of the public health agency's mission, including setting targets for quality and performance improvement, supporting a culture of quality improvement within the governing body at the public health agency, holding governing body members and the health director to high performance standards and evaluating their effectiveness, examining structure, compensation, and core functions and roles of the governing body and the public health agency on a regular basis, and providing orientation and ongoing professional development for governing body members. And finally, resource stewardship. Assure the availability of adequate resources, legal, financial, human, technological, and material to perform essential public health services. These may include, but are not limited to, ensuring adequate facilities and legal services, developing agreements to streamline cross-jurisdictional sharing of resources with neighboring governing entities, developing and approving a budget that is aligned with identified agency needs, engaging in sound, long-range fiscal planning as part of strategic planning efforts, exercising, that's a hard word, fiduciary care of the funds entrusted to the agency for its use, and advocating for necessary funding to sustain public health agency activities when appropriate from approving and appropriating authorities, which is gonna be a topic of conversation we dive into this afternoon. Let's see. And this is a source. Would you guys prefer I just read everything?
Yes, please.
Okay.
We can take turns too.
Get it. You wanna start?
Okay, yeah. Great suggestion. The Public Health Act of 2008. The Public Health Act of 2008 further formalized the structure and duties of local boards of health. The act requires that each county or district board of health consists of at least 5 members appointed by the Board of County Commissioners, to include county commissioners as well as county residents with expertise or interest in health and public health. In counties with populations of less than 100,000, a 3-member board can be appointed, and the Board of County Commissioners may designate itself, if there was not a Board of Health separate from the Board of County Commissioners prior to the 2008 Act.
And that's how you all came to be.
That's us. The Act states that local Board of Health members shall be residents of the county, and no business or professional group or government entity shall constitute majority of the board. Local boards of health provide administrative, policy, and financial oversight to the designated public health agency, and the duties defined within the Act include administrative, select, advise, and evaluate the public health director of the county or district public health agency, determine the services and set priorities to carry out the public health laws and rules of the State Board of Health and CDPHE's environmental commissions, according to the specific needs and resources available within the community and as set out in the state and local plans. Review and approve the local public health plan and submit to the Board of Health for review. Policy. Consider advice from the local public health agency regarding policy issues necessary to protect the public health and the environment. Develop and promote the public policies needed to secure the conditions necessary for a healthy community. Determine general policies to be followed by the public health director in administering and enforcing public health laws, orders, and rules of the county or district board. Follow orders, rules, and standards of the State Board of Health. Issue orders and adopt rules not inconsistent with the public health laws of the state. Financial. Certify that claims or demands against the local public health agency funds shall be expanded only for public health purposes. Annually estimate the total cost of maintaining the local public health agency for the ensuing year and submit a budget to the county commissioners. Provide for and assess fees to offset the actual direct costs of environmental health services. Accept and, through the public health director, use, disperse, and administer all federal and state aid or other property and services or money allotted to an agency for county or district public health functions. Boom, thank you.
Yeah.
That kept me engaged.
Right?
Yeah, for
Who's
sure.
excited to be engaged next? I had a feeling it was you. Okay, so Colorado Core Public Health Services
Colorado
Framework.
context.
Yes.
The image below displays the Colorado Core Public Health Services Framework, mandated by the 2008 Colorado Public Health Act. This law requires the State Board of Health to define the essential public health services that each county and district public health agency must provide or ensure, and to establish minimum quality standards for those services. Colorado foundational public health services include maternal, child, adolescent and family health, environmental health, communicable disease prevention, investigation, and control, access to and linkage with care, chronic disease, injury prevention, and behavioral health promotion. Colorado foundational public health capabilities include assessment and planning, communications, policy development and support, partnerships, organizational competencies, emergency preparedness and response, health equity, and the social determinants of health. Since January 1st, 2020, Colorado has mandated state and local health departments to deliver 7 foundational capabilities and 5 foundational services as outlined in the 6 CCR 1014-7 Core Public Health Services. The Colorado framework is based on the National Core Public Health Services Framework created by the Public Health Accreditation Board, PHAB. What are core public health services? Foundational services are the subset of services in each public health program area, foundational to the building and maintaining of healthy communities. Foundational services refers to a critical subset of services within every public health program area. These services are fundamental for the establishment and maintenance of healthy communities. They are crucial in laying the groundwork for the overall community and health and well-being. What are the core public health capabilities, you might ask? Cross-cutting capacities and expertise are needed to support foundational services and public health programs. There are 5 core public health services and 7 core public health capabilities. Each service and capability has its functions. Foundational capabilities encompass a range of essential skills, knowledge, and resources necessary to effectively uphold crucial services and facilitate the functioning of any public health initiative. These capabilities are the fundamental building blocks for supporting and sustaining various aspects of public health programs and initiatives. How does this relate to the Board of Health? As stated above, local public health agencies are mandated to deliver core public health services and foundational capabilities. LPHAs work to assess their community's needs, community health assessments, and then develop plans, community health improvement plans, to address those needs. Boards of health are required to certify those plans as well as be knowledgeable of the data used to create them and the outcomes of the department is hoping to achieve.
And what you just spoke to is what is on this sheet, and we will refer to this again and again, right? And this is like, we are required by law to do this as public health.
When people refer to the core functions, this is it, right?
Exactly,
Okay.
yeah, which is, and so there's the foundational public health services and then the capabilities. So these are things that we're statutorily required to provide in some form. And what they're talking about here, this community health assessment, that is what I've talked about. We're required to do a community health assessment every 5 years. And then with the data we get from that assessment, we come up with a community health improvement plan. We are engaging in that right now.
When's it due?
The end of the year. We need to have the community health assessment piece done by the end of the year. And then next year we'll work on the improvement plan.
How's the health assessed?
So we have a contractor that we're working for. There's a number of different ways, and it's kind of up to us how we do it. And there's guidance from the state, but we collect data. There's a lot of quantitative data that's already available to us that lots of other people have gotten. So we go look at that qualitative data, and then the quantitative data, we can come up with, like, we can decide if we wanna do a survey for the community, if we wanna do some sort of meeting with one-on-one community members, if we wanna do small groups. So there's a couple different ways to go about it, and we haven't figured out exactly how we're gonna do that yet. We're trying to be mindful of, there's a lot of community engagement going on from different departments right now. Like we have the One Community Project, where there's doing a lot of community engagement, which is great, but we don't wanna we're trying to be mindful of what they're doing and do it a little different and not over survey our community and therefore have people not engage. So that's the conversation I'm having with our contractor of how we're gonna go about this, and we're in the early stages of figuring that out.
One thing I do notice is that it's usually the same people engaging
Yeah,
in the room.
yeah, and it's important to make sure we're actually getting all members of the community, especially the vulnerable populations who we are really, a lot of our work is aimed at, providing vaccines for free and blood, I mean, for everyone. So that's something we definitely keep in mind, is how are we actually going to engage with all of our community.
Couple quick questions. When you talk about the end of the year, are you talking about the end of the county's year, or the end of the state year?
2025.
Okay, yeah,
Great question.
just keep in mind that state stuff runs, you know,
Yeah.
July 1 to June 30th instead, so the
Yeah.
end of the county's year.
Yep.
The other thing that's important to keep these things in mind, and I think we're gonna be talking about this later at some point, is the funding for these things and how important that might come, because we could very well find ourselves in situations where we have these unfunded mandates come through.
Exactly.
And so it will require y'all to do some creative thinking of to how we're gonna fund these other things that we're required to do.
Yes, that's part of why I printed those out, and yeah, you will see this exact thing again in a slide later on this afternoon.
What did I miss there?
I was just.
Tom is proud of all of the podcast voice we have in the room.
Oh,
Tim,
Tim. Yes.
minus mine. Great, so
I can't read, so I'm gonna pass on my
that's great, no problem.
reading.
You are welcome to do that. Summary and resources.
I'll go next.
Oh, yes.
Yes. On behalf of CDPHE, thank you for caring for your community by being a Board of Health member.
Voluntold.
The drop-down chart below contains a summary of the information already presented in this training. If you'd like to access these summaries, use the plus to open each section. This section is optional.
Are we feeling like we would like to review, or are you feeling okay?
Feel good.
Okay, anyone else? Speak now or forever hold your,
Do you think it's important for us to review this section?
I don't know, I think you guys did a great job paying attention.
Okay.
Yep, this
It's
is
what
just
we've
what we're
already
doing.
Oh, these are just
Yeah, we're just, yeah,
refreshes
sorry.
already.
Yeah.
It's still pretty fresh, you
Yeah,
know?
great. And then below are some tools, resources, and training opportunities that have worked for some Board of Healths across the state. As every Colorado county is unique, discuss these resources with your board and executive director to determine what might be useful. We are currently doing this. This National Association of Local Boards of Health, there's a little bit of information on this paper right here that I printed out for you, the governance functions. And then these Colorado revised statutes, I can get you guys all of this if you would like, and just send you links to this if you ever wanna review it later.
Do you just get to call that an elbow, like elbow with an N?
I think we can call it that if we would like.
An elbow.
An elbow. Okay, and thank you to our partners. Thank you for completing this course. Okay, alright. Well, okay, we can hit quit. Just wanna make sure we get credit for it, I know. Okay. Don't worry, you're not off the hook, we'll get you going here.
Am I reading?
Yes.
Is this the full 3 hours, is us reading through these things?
Yeah,
Okay, cool, just wanna set
well,
my
and
expectations.
this is the first time, so for 2025, historically, it's not been quite like this, like maybe there'd be a video and someone would be talking at us more of the whole time, but they've made it more engaging. So, there's also a couple of different ways we can do this. One is like you guys could have all done this individually on your own time, however, in the past, that has not been an effective way to get this accomplished. And last year, I don't think any of the Board of Health members did it, even though we asked. You know, it's just a hard thing when you have a lot on your plate to prioritize doing this. So with you all being new, it felt really important that we made sure you did this training. So it's a little painful, but this is how we're gonna do it. Yeah.
I had this on my chalkboard, I thought I was supposed to do this before I got here, and I walked in here like, oh my god, I didn't do that.
No,
Or
well,
it's-
there was a small one that they used to have you, even if we're gonna do it like this, have you do one on your own.
Okay.
But we're
Maybe
doing
that's
it
the
all
one I got
together.
the
Yep,
link
that is
to
what
there.
that was.
Okay.
Okay, recap of that first one. Is there anything else we wanna talk about before we move on to this next one?
Just those due dates, so the community health assessment is due by the end of this calendar year.
More or less, and it's fairly flexible, so I'm in constant communication with the state and the Office of Plan and Development, and because when it came to do this, there's a number of different ways, like there was a grad school class that was interested in engaging with us in our community health assessment, but they wouldn't have been able to take us on until the fall. And so I was, there's a world, they're like, if you really wanted to do that, we're okay, like they're pretty flexible as long as you're communicating about what's going on. Also, I was like, hi, I'm brand new in this position, I'm still learning how to do my day-to-day tasks. I'm doing my best, like, if this was to be a little late, as long as I'm in constant communication with the state, that's okay. But the idea is every 5 years, you're assessing your community. And so for some context, historically, we have actually done this in partnership with the hospital and with LC-BAG. And we would do it, because they have to do a similar thing every 3 years. So the last time we did this was 2020, and we did it with the hospital and with LC-BAG. At the time, this was before I was here, I don't think the Board of County Commissioners was particularly excited about the outcome of that as it related to public health. It didn't feel maybe as focused on public health and actionable steps like that we could do. So in 2023, we also had a lot of staff turnover. I think that was when the current public health director resigned. So it didn't happen then with them. So here we are. Now there's someone in this role, it's 5 years, it's time to do it. How we decide to do this going forward, we can talk about and can be a conversation and decide if we want to try to do it back again with the hospital and with the nonprofit, or if we just keep doing it on our own. And we don't have to talk about that now, but planting that seed. It's nice to do it in collaboration with other community partners, because then you can reach more people, you're all on the same page of what's going on. But then there's just more people at the table. Regardless, part of this community health assessment is we have an advisory committee. We have some folks who sit on this, and I will probably be asking people from those entities if they'd be willing to join as part of this process.
Foundational public health services, I see chronic disease listed. There's never in the history of this country been a situation of anyone below the state level banning like Red Hot Cheetos or something like that from the grocery store in the name of chronic health, chronic disease prevention or things like that. That's always only state level and federal. There's like nothing below that.
We will not be
have no
banning that,
levers.
no, but RFK might.
I will say, we did, at the end of 2024, implement a local tobacco retail license ordinance and regulation, which does aim, to prevent chronic illness
Locally.
locally.
So we do identify areas locally that we do have power to work towards chronic disease prevention. For example, our whole blood lead testing program, right? To prevent like high blood lead levels, this radon testing program, exposure to high radon levels results in lung cancer, can result in lung cancer after a long time. So for example, radon testing, making sure people are testing wherever they live or where they're working and making sure they're not exposing themselves to high levels of radon. So we are doing it in our own way,
Okay,
that we can at this
that
level.
we're allowed to.
Yeah.
Yeah.
Yep.
I just get anxiety when I go to the grocery store and I watch these grocery carts get filled up with little kids hovering around them I'm like, oh my god.
With food byproducts, not real food.
Stuff
I know.
you're feeding your
I
children.
know. Yeah, and so what we can try to do, right, is like education, health promotion, like it's, yeah. But we cannot at this time ban hot Cheetos.
Alright.
Go call the care clinic, we can't move back in until Friday.
Okay, thank you for doing that. Well, I guess you got out of reading this time.
I will read next time though.
Okay, so local boards of health are critical members of the population health system and public health workforce. This training is intended to equip new board of health members with a foundational understanding of public health and provide them with information that is important for supporting the community's local public health agency and leadership. This course is designed as an overview of the history, structure, and definition of public health in Colorado for local and state Board of Health members as part of their required yearly training plan. Find out more about the Board of Health yearly trainings here.
Stop it.
We actually already covered this. This is feeling slightly redundant from the first one we did.
Yeah, there's our 6
Don't do
sections.
it. No, we already did this.
Yeah,
Is this the exact same one?
Yes.
Nope.
No,
There we go.
there's a
We got to
history.
Let me see, I wonder if it's gonna make us hit those to be able to, no, it will not, great. See, this is fun.
So funny.
Congratulations on being part of the public health system. Local boards of health are critical members of the population health system and public health workforce. Boards of health are often composed of members from interdisciplinary backgrounds. This training is intended for Board of Health members to have a shared understanding of their role in public health in order to most effectively draw upon their diverse expertise. The goal of this training is to equip new Board of Health members with a foundational understanding of public health and provide them with information that is important for supporting their community's local public health agency and leadership. Public health is not new, even though our work is often behind the scenes to keep people and the environment healthy. The audience for this training is Board of Health members and public health professionals working with boards of health, but may also be appropriate for anyone in public health. This course is the first step in a learning pathway about public health. During this course, you will learn about the history of public health in Colorado, the foundational principles, framework, and core services of public health, how public health differs from health care, public health structures and services in the United States and Colorado, the roles and requirements of entities within and adjacent to public health. As an introduction to public health in Colorado, this video takes us through time as we continue to make Colorado a great state in which to live.
Great.
Keep saying like what we're going to do.
I know, let's do it, huh? Okay, let us introduce you to the history of public health in Colorado through this video. Fun. Okay,
Okay.
settle
Good
in,
one. Yeah,
settle
good
in.
one.
Let's learn some
Brought
stuff.
some popcorn.
The territory that became Colorado was once known as the land of the Blue Sky people. The Native Americans of Colorado, who included the Ute, Cheyenne, Arapaho, Kiowa, Comanche, and Pawnee, lived in harmony with nature. Because of their sparse distribution in small communities scattered across the land and conservative way of life, their culture was their public health protection. In the early 1800s, news of the explorations by Lieutenant Zebulon Pike and Major Stephen Long were reported in the east. This brought trappers and traders to Colorado in search of valuable furs. The first real migration of settlers to Colorado consisted of ranchers and farmers in the mid-1800s. Wagon trains traveled the westward routes to California, Oregon, and New Mexico, with many main and secondary trails passing through Colorado. These often proved to be perilous journeys with high mortality rates for travelers. Epidemics of diseases such as tuberculosis, measles, and smallpox, as well as injuries and accidents accounted for many of these deaths. Some have estimated that there were 10 graves per mile on the main trails. One of the deadliest diseases to strike the travelers in the wagon trains during that time was cholera. In 1849, an outbreak of cholera occurred in Julesburg, a significant stopover site situated at the crossroads of several trails in the northeast corner of Colorado. Passengers from the wagon trains shared contaminated water, leaving many sick and dead. Despite the risks, people continued to go west. Soon, joining the miners, merchants, ranchers, and farmers was another group known as health seekers. These people were lured to Colorado in the belief that the dry climate, mineral springs, bright sunshine, and high, cool mountain air would cure tuberculosis, asthma, and a variety of other illnesses. From 1870 through 1880, the territory's population increased fivefold, from nearly 40,000 people to 195,000 people. And Colorado was being called the World Sanatorium. It was estimated that 1/3 of the new residents had migrated to Colorado to seek health for themselves or their families. Some citizens complained that Colorado was becoming overpopulated with people infected by contagious diseases. But the erroneous belief in the healing powers of the climate and mineral waters remained popular.
Erroneous.
Then a discovery was made that would change the course of history in Colorado. Gold. Pikes Peak or bust became the rallying call of the 59ers, and the rush for riches was on. Camps and towns seemed to appear overnight. Many of these settlements were built along rivers and streams with little concern for sanitation. The rapid growth in population resulted in waterborne diseases such as cholera and typhoid fever. While communicable health concerns were growing, a new kind of health problem was emerging: environmental pollution stemming from the burgeoning mining industries. Using all forms of mining techniques, miners seeking gold, silver, lead, and zinc worked Colorado's mountains extensively. Waste produced by mining introduced a new threat to public health and the environment. Land around the mining areas was destroyed by erosion, and the nearby water sources were polluted by acid mine drainage. The full extent of these impacts would not be realized for more than a century. In 1876, Colorado was granted statehood. Denver was beginning to prosper, but not without some growing public health concerns. Dr. Frederick J. Bancroft, president of the Territorial Board of Health, called Denver the dirtiest city in the United States. He was among a growing number of physicians calling for Denver city officials to provide sewers, odor abatement, alley cleaning, and the regulation of domestic animals. In 1877, the newly established State Board of Health was charged with recording the causes of illness and death, controlling epidemics, and providing advice on proper sources of water and places for sewage disposal. Despite the growing awareness of public health issues, epidemics continued to take their toll on Coloradans. In southern Colorado in 1877, a smallpox epidemic broke out, causing a reported 844 deaths in 3 counties. 2 years later, an outbreak of typhoid in Denver made an estimated 1,200 people sick and resulted in 47 deaths. The State Board of Health blamed this outbreak on foul air, filth-sodden soil, and polluted water. Despite the passage of several laws to control communicable diseases, the board was not granted the power to enforce existing health laws. The dawn of the 20th century found a Colorado that was in transition. It became clear that to achieve community health, one had to look beyond the perspective of the individual. Public health problems needed to be dealt with and controlled from a community-based perspective. By 1900, Colorado's population had climbed to over 500 million, and the rapid influx of people was causing growing pains. The boom days of the gold rush had, for the most part, gone bust, and the state was being industrialized. Mining and smelters were drawing new immigrants by the thousands, and the railroads eagerly helped transport them to this new land of opportunity. Farmers were starting to form co-ops, so that it was affordable to build dams and provide irrigation to the arid prairie. Amidst these changes, the perception of Colorado as the world sanatorium was declining. It was at about this time that tuberculosis was determined to be a communicable disease. The belief in the state's climate as a therapeutic remedy was giving way to more traditional forms of medical treatment. Epidemiological techniques to control the spread of disease included quarantines, immunization, and other new treatments. As a result, hospitals and sanatoriums began to dot the landscape throughout the state. Still, there was a general lack of public support for health issues at the turn of the century, and resources for public health were meager at best. Unless there was a disease outbreak, people were complacent about taking measures to protect public health. Water management and sewage disposal received only cursory attention from government officials in the business community. As the population of the state kept growing faster than the national rate, the problems with filth diseases only worsened. This especially affected children, resulting in infant mortality rates that were much higher than the national average. In 1901, the State Board of Health, with a staff of 2, issued its first complete mortality report, which listed the consumption, diphtheria, scarlet fever, pneumonia, and heart disease as some of the leading causes of death. Later, the board widened its scope of responsibility to include such functions as birth and death registrations, consumer protection programs, and public health nursing. Despite the efforts of the board at this time to prevent and control diseases, the Spanish flu still caused 7,000 deaths in Colorado. During the 1930s, the State Division of Public Health continued to grow, adding programs such as mother and child health and milk products control. In spite of making these gains, the division still lacked the resources to meet all the public health needs of Colorado's citizens. Then something happened in Colorado that was as significant to public health as the gold rush had been to the state's growth in population and economy. The year was 1944, and the governor of the state, John Vivian, appointed Dr. Florence Sabin to chair the subcommittee on health of the state's post-war planning committee. The subcommittee was charged with examining the condition of public health in the state. Dr. Sabin had recently moved back home to Colorado after a career as a distinguished scientist from the Rockefeller Institute. She not only brought with her a reputation as one of the world's leading researchers, but she was also the first woman professor at Johns Hopkins University and had been elected as the first female member of the National Academy of Sciences. While the governor was assured that this 73-year-old retired lady would not upset any apple carts, he would soon find that Dr. Sabin was not about to stay quietly in the background.
Yes, then the governor was planning a post-war planning committee, and incidentally put me on it. He didn't know anything about me, and it's rumored that he thought I was an old woman and no harm could come.
She immediately asked for a statewide health study. The results of that study armed her with facts that ranked Colorado as one of the worst in the nation for deaths from preventable and controllable diseases. Dr. Sabin then spent the next several years barnstorming every county in Colorado to inform the citizens of the need for stricter health laws. She rallied the public, community leaders, and industry to persuade the Colorado legislature in 1947 to pass what are now known as the Sabin Health Laws. Not since statehood in 1876 had there been any major revisions of the state's public health regulations. Her efforts led to a new kind of modern public health in Colorado.
The legislators knew about it all over the state, and we kept a pretty careful watch, and it went through quickly. We had 2 bills, one set up a good modern health department, and the other permitted legislation to allow our counties to organize their health. Those are 2 main bills, and they both went through.
To recognize Dr. Sabin for transforming one of the nation's most backward health codes into one of the most progressive, Coloradans chose her as the first distinguished citizen whose statue would represent this state in the U.S. Capitol in Washington, D.C.
Cool. I didn't know.
But it wasn't just in Colorado that a renaissance in public health was occurring. Food products were being more closely regulated, and government programs provided immunizations for diseases such as polio. Colorado's population jumped by nearly 33% during the decade of the 1950s. Public health issues intensified as people poured into the urban areas with additional demands on water supplies and sewage and waste disposal. Rural areas began to experience greater difficulty in providing basic health services and adequate medical facilities. In addition to the long-standing health issues, there were growing environmental concerns. It was not until the next decade, however, that the environmental movement would start to attract the public's attention and support. Nationally, the 1960s were a time of great social upheaval and the start of many people's personal involvement in environmental issues. In 1962, Rachel Carson published her revolutionary book, Silent Spring, which revealed the toxic effects of pollution and pesticides on the environment and galvanized the country into supporting new standards for the use of toxic substances. With this growing emphasis on the environment and the passing of public health legislation, Colorado health officials responded by turning their attention to pollution in the air, land, and water that resulted from population growth, industry waste, and negligence. At stake were the health and the beauty of the state. As a result, there was a real sense of urgency to start resolving some of these environmental issues. By 1963, an air monitoring network was set up, which today covers the majority of the state. In 1970, the Colorado Department of Health began taking environmental samplings around the Rocky Flats nuclear weapons plant, northwest of Denver, in order to find out if the air, water, and soil around the facility was contaminated with radioactive materials. A 9-year comprehensive study of the potential health effects from radioactive and chemical emissions was completed in 1999. In the mid-1970s, the state health department became aware of uranium mill tailings that were being used as fill materials for homes and businesses in various areas of western Colorado. State and federal funds were used to clean up many of these sites. More recently, medical monitoring programs have been established to track potential health problems from exposure to toxic metals, chemicals, and pesticides at 2 Denver area cleanup sites, the old Globeville plant and the Rocky Mountain Arsenal. To help with the elimination of filth diseases, sewage and waste disposal systems were upgraded so that by 1966, 97% of Colorado's population was being served by some form of secondary or complete treatment facility. The infant mortality death rate in 1967 was less than 1% above the national average, a vast improvement over the infant mortality death rates at the turn of the century. The federal, state, and local health officials continue to be called upon to respond to public health emergencies. These include the floods that inundated the Arkansas and Platte River valleys in 1965, and the Big Thompson flood in 1976. In 1997, E. coli 0157 was traced to hamburger processed at a Nebraska plant. This disease detective work led to the largest meat recall in the nation's history. Public health continues to be primarily involved in the collection and analysis of data to determine how to provide better public health services to the citizens of Colorado. For example, in 1987, Colorado became one of the first states to require reporting of HIV and AIDS by both care providers and laboratories with strict confidentiality standards. HIV surveillance data are analyzed to locate communities at risk, to identify gaps in prevention and medical services, and to evaluate the effectiveness of various disease control and prevention interventions. Through these activities, the state and local health officials in Colorado have turned the tide on the epidemic, and the number of new cases is dropping off significantly. These efforts and others cover a wide scope of health and environmental activities conducted by the Colorado Department of Public Health and Environment, local health agencies, and county nursing services. These activities range from issuing permits, assuring compliance with air and water pollution standards, and for the disposal of hazardous waste materials. Other activities also include disease control and prevention programs to reduce preventable death, disease, and injury. State and local health officials work to coordinate local emergency medical service systems, provide regulation of certain consumer products and services, and oversee the registration and issuing of Colorado's birth and death certificates. Also included is the licensing and certification of healthcare facilities and healthcare services for low-income individuals or children requiring specialized care. The public health approach in addressing health and environmental issues over the past 30 years has been to employ a trained professional staff that is able to utilize advances in technology and to implement programs that are regulatory in nature. Good public health doesn't just happen. It affects everything we do, but it can easily be taken for granted. The future of public health will be shaped by all of us and the decisions we make. We must work together to assure that future generations will inherit a Colorado that is not only beautiful and clean, but continues to be a safe and healthy place to live.
I'd like to see a more updated version of that, like the history was good, but it seems like it stopped around the
Under the
1987.
Yeah, I was gonna say.
There's a lot that's happened
Been a
since then, but okay.
Okay, another one, yay.
Obviously, if you need to use the restroom, full water, whatever you need to do. Do it whenever you need.
What is public health? There are several definitions of public health. Here are two that are commonly used. Public health is defined as the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society. Public health promotes and protects the health of people and the communities in which they live, learn, work, and play. In both cases, public health professionals try to prevent problems from happening or recurring. It is important to note that in Colorado, public health also contains environmental health. Environmental public health can be defined as the branch of public health that focuses on the relationships between people and their environment. The field works to advance policies and programs to reduce chemical and other environmental exposures in air, water, soil, and food. Prevention is central to public health work. Let's look closer at one way to view prevention of disease or injury. Prevention may be viewed as a spectrum from A, preventing onset of injury and disease, or B, preventing disease or injury from becoming more severe, and C, treatment to reduce the impact of an ongoing illness or injury. This model of prevention focuses on when, during the potential course of a disease or injury, public health intervenes. To the left is primary prevention. Primary prevention aims to prevent disease or injury before it ever occurs. This is done by reducing or eliminating exposure to hazards that cause disease or injury, or by creating safer environments. Primary prevention may focus on everyone or on high-risk groups. For example, activities such as campaigns to avoid cigarette usage or tobacco age purchasing restrictions help to prevent tobacco-related diseases such as cardiovascular disease from occurring. Secondary prevention aims to reduce the impact of a disease or injury that has occurred. For example, early screening programs may catch a disease such as cancer at its earliest stages, thereby minimizing the impact of the disease. Tertiary prevention and treatment happens after an injury or disease and aims to improve the quality of life or reduce the symptoms. For a disease such as asthma, it may be clinical treatments or creating asthma management plans and eliminating exposure to asthma triggers. Often, when we think of prevention, we think of eliminating a risk, but public health also emphasizes creating the conditions to thrive. For example, available healthy foods, safe places for physical activity, healthy relationships, and social connectedness. These are all part of prevention and enable us to live healthy lives. Prevention reduces the number of people that get an illness or injury and need treatment. As we move left on the spectrum, this is called upstream prevention, and it reduces the number of people needing medical treatment downstream. This brings us to the difference between public health and health care. Public health focuses on the whole population, both healthy and sick. while healthcare has an individual patient focus. Public health has a prevention emphasis, while healthcare tends to focus on diagnosis and treatment. Of course, there are areas where public health and healthcare overlap on the prevention spectrum, but public health aims to keep as many people healthy and thriving as possible and away from disease and injury treatment in the first place. Clean air and water, safe neighborhoods, safe and healthy foods, and fair opportunities to thrive. It's the mission of public health to make sure our cities, communities, and country have what we need to be healthy. What does population health look like? Let's explore a few concepts in public health that help to illustrate. The health impact pyramid touches upon prevention and the scale of the impact. Let's start at the top of the pyramid and work down. Interventions at the top tiers are designed to help individuals rather than entire populations. Often more frequent encounters are needed at these levels. Counseling and education and clinical interventions, a program focused on chronic disease, may include strategies like dietary counseling, education to increase levels of physical activity, or treatment of hypertension. For the third tier, long-lasting protective interventions, vaccines are an example. This activity requires less frequent interactions and has a longer lasting effect than the first two tiers. It also can have a broad population level impact. Vaccines prevent millions of deaths among children around the world every year. In this case, a single dose or instance of an intervention can have a lifelong effect. The next level is changing the context. This level strives to create environments that are inherently healthy and to make healthy choices the easy choice. For example, prohibiting smoking in certain public areas, creating walkable communities, or removing contaminants from an environmentally impacted area. These changes have the potential to be long-lasting, affect whole communities, and require less individual effort. At the base of the pyramid are public health interventions that affect socioeconomic factors. Improving the quality of life by reducing poverty, providing basic sanitation, improving access to education, healthy food, and medical care can greatly increase a community's health. The scale of the impact is one aspect of effective public health interventions. The health impact pyramid touches upon the frequency of interventions as well. Other factors considered in public health programs include the intensity and effectiveness of an approach. Many public health efforts employ complementary strategies at multiple impact levels. But what really affects our health? Is it just medical care and individual choices? This chart, the County Health Rankings model from the Robert Wood Johnson Foundation, emphasizes that many factors influence how well and how long we live. Policies and programs are foundational to shaping our social, community, and health structures. Health factors represent those things we can modify to improve the length and quality of life for residents. These factors include the physical environment where individuals live, learn, work, and play, socioeconomic factors such as income, education, employment, community safety, and social supports. Access to affordable, quality, and timely healthcare can prevent diseases and detect issues sooner. And health behaviors are actions individuals take that benefit their health, such as eating well and being physically active, and actions that increase one's risk of disease, such as smoking, excessive alcohol intake, and risky sexual behavior. These all in turn affect our ability to live long and thrive as measured in health outcomes. We'll discuss health outcomes and length of life and quality of life measures later in this course. Notice the portion of the chart that represents clinical care. We spend trillions of dollars on healthcare, yet it determines about 20% of our health. Public health and prevention is not only beneficial for people and communities, but it also protects our healthcare system from being overburdened and overutilized. Properly funded public health programs are a cost-effective approach to systematically improving the overall health of communities. Individual and population health occurs in complex relationships with the individuals themselves, their families, relationships, communities, living and working conditions, as well as larger socioeconomic factors. which have daily and potentially long-lasting impacts on lives. This ecosystem may be beneficial or harmful to our health. Public health is especially interested in these modifiable factors that are the areas in which we can intervene or apply strategies to improve. Health impacts are not just single point-in-time events. A life course perspective shows that current health is shaped by earlier events. There are critical periods during human development where social or environmental exposure may have increased impacts. Repeated exposures or prolonged stress can also have a cumulative effect and influence health throughout one's life. Now that we know some of the drivers of health, how do we know if we are protecting public health? Health outcomes are measures that tell us about a population's ability to live long and thrive. Measuring how long people in a community live tells us whether people are dying too early, and it prompts us to look at what's driving premature deaths. We examine these through mortality measures. Quality of life refers to how healthy people feel while alive, including a community's physical, mental, social, and emotional health from birth to adulthood. These measures can show us how well we are doing in relation to other nations, states, and communities. We can also look at changes over time, or differences between different population characteristics like age groups, income levels, or race and ethnicity. Let's look at a few examples starting globally. Life expectancy is a common and important long-term public health indicator. We can compare populations to one another. In 2018, the US ranked 28th out of 37 peer countries with similar economic development. The US's average life expectancy of 78.7 years, behind Japan, Korea, Australia, Canada, most of Europe, and Chile. Public health can also delve deeper into data for specific segments of the population.
Cheetos.
Here, infant mortality can also be compared across countries. Over the past 50 years, improvement in the US infant mortality rate has not kept pace with peer countries. In 2018, the average rate of infant mortality among peer countries was 4.1 deaths per 1,000 live births, but the US averaged 5.7 deaths per 1,000 live births. These numbers will change over time, but global rates and rankings are just one way to look at how well we are protecting health. We can also look at health within the United States. Where you live can influence your health. This map shows the percentage of adults who consider themselves to be in poor or fair health. This is just one data point in the National Behavioral Risk Factor Surveillance System. Self-reported health status is a general measure of health-related quality of life. In addition to measuring how long people live, it is important to also include measures that consider how healthy people are while alive. We can look at these data to see trends over time or to compare places like Colorado to other states or to the nation as a whole. For our example of self-reported health status, we see that Colorado has less adults reporting that their health is fair or poor compared to the median percent in the US, and the percent has remained relatively steady in the past decade with a recent decline. Within Colorado, there are regional and county level differences in health outcomes like mortality, injury, or factors that influence health. Public health data not only begins to tell us how we are doing in protecting public health, but they also help us prioritize issues for public health improvement. In this example, we can see estimates of life expectancy by county and by census tract. There are over 20 years of difference depending on where you live. This is not unusual, and significant gaps in life expectancy exist across many United States cities, towns, and even zip codes. For public health, this is just the start of information that we would want to know. We need to dig deeper to look at the causes of premature mortality and the populations most affected in order to begin to put together a plan of action. In addition to mortality data like this, there is also county-level information about physical and mental health data, behavior, survey data, and socioeconomic information. Before we wrap up this discussion about how to know if we're protecting public health, we also need to look at not only geographic differences between health outcomes, but also subpopulation differences and inequities. The apparent improvement in any given indicator may be masking more complex underlying patterns and differences between groups. Public health ethics discusses how to prioritize our efforts given finite resources. We encourage you to explore the data in the resources section of this training. There is a wealth of information about health and the environment in your community. You may also read your community's public health assessment and improvement plan. Every 5 years, local public health agencies and CDPHE conduct these assessments that examine local health and quality of life information. The public health improvement plans must utilize community engagement to help inform and prioritize local health and environmental areas for improvement. In this next section, we will discuss the public health structures in the U.S. By looking nationally, we will have an understanding of the context for the public health system in Colorado. Local public health agencies, also called local health departments and abbreviated as LPHA or LHD, are in large and small jurisdictions throughout the United States. Nationally, 61% of LPHAs serve jurisdictions of 50,000 or less people at 9% of the total population. Only 6% of the agencies are considered large, with jurisdictional populations of greater than 500,000 people, and 52% of our nation's residents are served by these large agencies. Roughly a third of all agencies are medium-sized. Local public health governance looks different across the nation. In the West and North, the states in dark green have local public health agencies that are units of local government. This is the majority of the governance structures in the U.S., and Colorado also has this structure. In other states, LPHAs can be part of the state, as shown in dark blue, and some have shared local and state governance, or mixed models, in light green and gray, respectively. For all LPHA sizes and jurisdictional models, many LPHAs find efficiencies and economies of scale by sharing services with other LPHAs. Regardless of the size of the jurisdiction, just over half of the LPHAs share a service with other LPHAs or with the state. In Colorado, some examples of cross-jurisdictional sharing are for retail food inspections, epidemiology, nursing services, or environmental health programs. Cross-jurisdictional sharing may be narrow in scope with memorandums of understanding or contracts, as they may be shared positions or more broad partnerships. This list of potential programs and services by any given LPHA is long. The intent of listing the programs offered nationally is to provide you with a high-level overview of public health work. Public health services and programs fulfill core public health duties or respond to local needs and capacities. This chart shows non-clinical programs and the percentage of LPHAs nationally that have the respective program. These programs can be categorized as epidemiological and surveillance, which includes programs such as environmental health, communicable diseases, maternal and child health, chronic disease, behavioral risk factors. Population-based primary prevention includes tobacco, nutrition, and substance misuse. Regulation, inspection, and/or licensing includes retail food, school and childcare, body art, campgrounds, health facilities, and more. Environmental health services such as food safety, education, vector control, and water or air quality. Public health clinical services include immunizations, screening for diseases, screening for communicable disease, maternal and child health services, and other clinical services like oral health or healthcare. How are these programs and services funded? All LPHAs have a wide variety of funding sources. This chart shows the proportion of revenue sources nationally. Revenue sources for Colorado agencies follow similar patterns. LPHAs rely on local sources of funding, state funding, federal pass-through funding, and Medicare/Medicaid funding. Much of the funding that LPHAs receive is categorical and is contingent on delivering specific programs or services. Another way to look at funding for public health is to examine the relative public health expenditure per person across all states. Overall, the median annual expenditure for public health in Colorado is between $30 to $50 per person. This is mid-range in the United States. Colorado spends more than our neighbors to the north and south, but less than Kansas, Utah, Minnesota, Oregon, California, and several eastern states.
was wild that there wasn't a single thing that all of the public health agencies provide. I was like, wow, there's no like, this is public health.
Yeah,
Like the communicable diseases was the most shared and it was only 88%.
and I think it depends on the community and what other resources you have and
Yeah.
what other people might be providing those.
Right.
Like, so, yeah, I think
But it's just wild that no one thing lives with public health across the nation.
yeah, it's more just like the broad, like epidemiology and what that looks like exactly.
The third core concept is that public health ethics usually states that the right thing to do is the thing that most improves overall population health and reduces health inequities. Over time, we've done well at improving overall health, but unfortunately not at getting rid of inequities. To better understand this concept, let's look at the classic example of cigarette smoking. Over the last 15 years in the US, we have decreased both the number of people who smoke and the number of people who start smoking, which has improved overall population health. But at the same time, we have worsened the social gradient around smoking. Poor people are now much more likely to smoke than well-off people, meaning inequalities in smoking-related disease have actually increased. This is not optimal from an ethical perspective. Public health ethics says the right thing to do, if possible, is to both improve overall population health and reduce health inequities. These are called the twin aims of justice. Historically, an example of success in doing this is the expanded use of public sewer systems and garbage collection. In the past, well-off people enjoyed much better access to sewers and garbage collection than poor people, which created an inequity and lots of additional illnesses among poorer people. When public sewers were created, this helped everyone, but poor people enjoyed proportionally more of the benefits. Sewage and garbage collection services hereby achieved both of the twin aims.
Okay, back to Kelsey's talking.
In this part of the training, we will explore Colorado more closely, discuss the Public Health Act of 2008, and delve into the roles and responsibilities of the local public health agencies, including local boards of health. Colorado is a diverse state. 47 of the 64 counties are rural or frontier, and 77% of the land in Colorado is considered rural or frontier. Historically, Colorado's governmental public health system was
Bifurcated.
Thank you, bifurcated, with residents living in more urban counties and comprising approximately 85% of the state population being served by public health departments, while those in more rural areas were served by nursing services. Lake County used to have a nursing service, that's what we were.
I'm looking up what bifurcated means.
It means to split into two.
Yeah,
Oh, they could have used the way easier word for that.
Split into two with residents.
I did just learn a new word, so thank you for joining me. Thus, local services were delivered through two alternative governance structures with different authority, administration, and financing, and often providing significantly different services. I can't see that.
County designations.
Urban, rural,
Yeah. I would be.
Or rural.
Or rural,
Rural.
not frontier, but there is a lot of frontier and
rural and urban counties approximate. Did Park County have a urban and rural approximate on it? That
that's
seems
what it
weird.
looked like, yeah.
Why would,
they're confused.
they've never been to that part of Park County.
Yeah, that was like the mountains, that was like
Yeah, that was
Swatch.
very rural. Rural.
Today, all Colorado counties are unified as a single public health system. The Public Health Act of 2008 aimed to create consistency in the structure of public health agencies, including creating a minimum array of services and programs called the Core Public Health Services. This map shows the single county LPHAs in 2021. Blue partnerships and districts in 2021 are in dark blue and orange respectively. In Colorado, governmental public health is decentralized such that the Coloradoans are served at the state level by CDPHE and at the local level by LPHAs, where local governments retain authority over many decisions related to their budget, public health orders, and the appointment and employment of local health officials. While the Public Health Act created uniformity in the structure, LPHAs are not monolithic. They vary greatly in size, number of employees, and serve the unique areas of the state in which they are located. At the beginning of 2021, Colorado had 53 LPHAs. 9 of the agencies serve 84% of the population, that's wild. 44 of the agencies serve 16% of the population. Small agencies have 1 to 5 staff wearing many hats. We can confirm that that is true. 7 accredited health departments, 6 LPHAs plus CDPHE.
Is that it? So we go up again? 6 LPHAs.
I don't know,
What's the
Is
color
that
code?
true?
no, I don't know what that means. We have 53 LPHAs.
Yeah, why is it?
But
This-
only 7 of them are accredited.
What is
Yeah.
that? What's the
Like,
difference?
they have their own internal, Dr. Lisa, like instead of us using her license, is that maybe
Oh, okay,
accredited?
maybe.
Well, it says they're LPHA plus CDPHA, I don't quite understand what that means, but that is not us, so.
Yeah.
So we will figure it out.
Right. Colorado public health structure prior to 2008. In this map, the white areas are counties served by nursing services, and the colored areas show health departments prior to the 2008 Public Health Act. The gray circles show where there were environmental services which were not part of every LPHA.
So we had nursing services and environmental services separate. Were you around then? Prior to 2009, okay.
The reorganization of the public health system was the result of the passage of the Colorado Public Health Reauthorization Act, Senate Bill 08-194 in
Look what you
2008. Well, I wasn't gonna, The goal of this act was to ensure that public health services were available to every person in Colorado with a consistent standard of quality regardless of where they lived. The Public Health Act recognizes that prevention of disease and injury saves healthcare costs as well as creates environments where all people can thrive. Healthcare is fundamentally about treatment, which is critical to the health and well-being of residents, and it works in tandem with public health, which focuses on prevention. The act requires that each county establish and maintain a county public health agency or participate in a district public health agency. Any 2 or more contiguous counties may establish a district public health agency.
I didn't know that, so theoretically, we could
do that.
Chafee one day if we ever needed to.
Or Senate.
Wonder if it's safe,
Just
save
hard.
money.
Someone with more money.
That's not too far.
No. Local public health agencies have a duty to provide or arrange for the provision of quality core public health services deemed essential by the state board and the comprehensive statewide public health improvement plan. Core public health services are comprised of foundational capabilities and foundational public health services. 1. Foundational capabilities are the cross-cutting capacities and expertise needed to support foundational services in any public health program. 2. Foundational services are the subset of services in each public health program area that are foundational to building and maintaining healthy communities. Colorado 6 CCR 1014-7 goes into each of these capabilities and services more in depth. You are encouraged to explore this administrative goal.
We've reviewed this is what we have in front of us here, our foundational services and our foundational capabilities. We're gonna have these memorized.
Alright.
Let me know if you need a break.
Last one.
Colorado 6 CCR 1014-9 sets out the minimum quality standards for these core public health services. This rule recognizes that each community in Colorado should provide high-quality public health services regardless of its location. It also sets out that the public health system will adopt measurable standards so that Colorado's public health system will continuously improve the quality of its services and programs, demonstrate accountability, and raise public health capacity. Use national standards developed by the Public Health Accreditation Board, recognizes that local public health agencies are essential to the provision of quality and comprehensive public health services throughout the state, and are critical partners with the Colorado Department of public health and environment, and maintaining a strong public health system.
Okay.
Nice work.
In this part of the training, we'll cover components of the public health system in Colorado and the roles and requirements of entities within and adjacent to public health. Okay, we've got the State Board of Health, the Colorado Department of Public Health and Environment, local boards of health, and local public health agencies. So CDPHE, we refer to them a lot, we go to them for all sort of guidance and information. The ecosystem of public health also includes a variety of partners, academic institutions, associations, and organizations that have close linkages to public health. So the State Board of Health is a 9-member that was established in 1877 by the Act of Colorado's first General Assembly. State Board of Health members are appointed to staggered 4-year terms by the governor. 1 member is appointed from each of the Colorado's 7 congressional districts and 2 members from the state at large, and 1 board member must be a county commissioner, and no more than 5 members can be from the same political party. Primary duties of the State Board of Health established by state law are to adopt or revise standards, rules, regulations for public health, determine general policies to be followed in administering and enforcing the public health standards, rules, and regulations, act in an advisory capacity to the executive director of CDPHE, establish and appoint special advisory committees when necessary, approve grants for a variety of public health efforts. Examples of specific rules promulgated by the State Board of Health responsibilities. Promulgated. Directly to LPHs are establish core public health services that each county and district public health agency must provide or assure, minimum quality standards for public health services, minimum qualifications for county and district public health directors and medical officers, evaluation criteria for public health improvement. What?
There's 16 things.
Yeah, this is in, oof, other state boards and commissions.
My turn. Okay.
I could use a quick break.
I could do, let's
you,
take a quick break and
10:30.
We can also read some of these amongst
read that at
ourselves,
home?
like as we just.
you'd have to create an account and log back
Okay.
in and.
No, I mean like, we can
Yes.
just read them here
Yes,
in the
okay,
room
that's a great plan.
without, like,
Yeah. Okay, let's
read
take
them
a
quietly
quick
to
5-minute break
everyone-
and come back
Yeah,
here.
like everyone could just say, okay, I'm done, okay,
Yeah,
I'm done,
that's
you know.
totally fine.
Instead of this orating, it's just, you know, ambitious, and I respect the,
pronunciation of words.
yeah, I mean, I just looked up promulgated, and I'm like, there's not 10 different
There's-
words they
I
could have
know.
used for that.
It's way too wonky.
We're trying to church it up, alright, you know,
Church it up.
like.
This is so boring. It's astounding.
No, nothing against the department itself.
The work isn't boring, this presentation
Yes.
is done, I think they've referred to the core policies like 17 times.
Thank you for suggesting the break. We are back.
Yeah, just one word.
Okay, so there are 2 types of board. We've got type 1, we've got type 2. Type 1, at CDPHE, in addition to the Board of Health, include the Air Quality Control Commission, Solid and Hazardous Waste Commission, and the Water Quality Control Commission. Examples of type 2 include Long-Term Care Advisory Committee, Pollution Prevention Advisory, Health Equity, Child Fatality Prevention System Review Team, and many others.
Wait, which one are we?
Both, right? You just-
Oh, other state boards.
Yeah.
Okay, sorry.
You know, it's okay.
Don't ask questions. Just click.
Ask questions.
I'm kidding.
LPHAs, this is us, consist of
Oh, okay, got it.
local board of health, director appointed by the local board of health, medical officer,
Lisa.
and relevant personnel to carry out duties such as environmental health specialist,
Kelsey.
public health nurse, health educator, epidemiologist, health planner. All kinds, we've got our own staffing structure. For LPHAs that did not have a board of health, we've already learned about this prior to 2008. Each county board of health, you can appoint a 5-member board of health that for 5-year terms. Counties with populations less than 100,000 have 3 board members, which are you all. Members must reside within the county and appointments must be, so no business, we've already read this, okay? And then, yes, this is who we are, and this is how you all are who you are. This is not us, so we're just gonna move on. It is recommended that all local boards of health have members with experience in areas, but this is not us, because you are our Board of County Commissioners. So you're not here because of your specific public health background, which is why we're talking so much about public health. Okay, this is important. These are our local Board of Health guidelines.
Okay.
Once a president and all other officers is desired is elected, so here we all are. Meetings must occur every 3 months. So we have quarterly meetings. Special meetings can be called by the president, LPHA director, or a majority with 3 days' notice, or 24 hours notice in case of an emergency. We can adopt bylaws. Majority is a quorum, and members cannot be compensated except to be reimbursed for expenses, which we shouldn't really incur. Responsibilities: selecting the director, securing a medical officer, approving LPHA's public health improvement plan and submit it to the state, which we'll be working together on. Within 30 days of appointing a new public health director, the Board of Health must submit the minimum qualifications form to CDPHE. I did that. To provide, equip, and maintain suitable offices and all necessary facilities for the proper administration and provision of core public health services. Act as an advisory capacity for the public health director, hold hearings, administer oaths, subpoena witnesses, develop and promote the public health policies needed to secure the conditions for a healthy community by considering the advice and expertise of the local public health agency, issue orders and adopt rules consistent with the laws, rules, and orders of the state and state board for public and environmental health issues that pose no immediate threat, like nuisance abatement. After the public health director is appointed, a minimum qualification forms reviewed. A physician candidate, doctor, this is all these things, or this is our Board of Health director, this is me. Must have a master's degree within the past, this is all done, this has all been taken care of. In the future, if you were to hire another Board of Director for public health, just know that there's certain requirements that the state has, and you'll have to either make sure they have them or submit some sort of documentation saying what they have that's similar, and they'll have to approve it. Directors that do not meet these minimum qualifications may be reviewed for a substitution or waiver. That's exactly what I was talking about. Public health director is separate from the local board of health and has responsibilities and powers that are unique to that position. It is important to note that the LPHA director may act as the secretary of a local board of health, but may not be a local board of health member. The public health director administers and enforces public health laws, exercises all legal powers such as the closure of schools or businesses, acts as the registrar of vital statistics, directs resources to carry out the public health improvement plan and community health assessment, issues orders during a public health emergency, and the public health director manages all LPHA staffing decisions. In our case, we have a director and we have a deputy director. Kelsey and I do most of those things together, and when I was out on maternity leave, she was essentially acting in the director role. Before I was hired, she was essentially acting as the director role. The Public Health Act specifies that each LPHA has a treasurer. Single county LPHAs must have the county treasurer serve as the agency treasurer. Okay, that's us. The treasurer creates a public health fund to which shall be credited all monies appropriated from the county general fund, any monies received from the state or federal appropriations, or any other gifts, grants, or fees. Funds credited to this account must be expended only for public health. Yes. Treasurer continued. On or before September 1st of each year, the public health director along with the local board of health should estimate the total cost of maintaining public health budget. We do this. We work closely on our budget with you all throughout the year, which is great. Single county LPHAs, the estimate shall be submitted in the form of a budget to the Board of County Commissioners, and you appropriate funds. They do a great job of having all departments do this. The county attorney, for the county or district attorney of the judicial district, shall bring any civil or criminal action requested by a county or district public health director for violation of the enforcement of public health laws and standards, orders, and rules of the state board or county or district board of health. The LPHA attorney is the legal advisor of the agency. The local board of health or public health director may also retain or employ an attorney to defend the agency and the officers and employees of the agency against all actions and proceedings brought against them. That is where Chris comes in. It helps us a lot. Sunshine Law and Cora. Finally, the boards of health should be aware and familiar with the opening meetings law, which is part of the Colorado Sunshine Law. This law requires any state or local government body to discuss public business or take formal action meetings that are open to the public. For local government bodies, 3 or more members of the body, or 2 members if 2 constituents a quorum, conducting business are subject to this law. A meeting refers to any kind of gathering convened to discuss public business, whether in person, phone, electronically, or remote, by other means of communication. The Colorado Open Records Act, or CORA, also pertains to local boards of health. This provides that all public records shall be open for inspection by any person at reasonable times, except as provided in Part 2 or as otherwise specifically provided by law.
Dang.
Knowledge check!
Let's do this, I love tests.
Okay, great. Let's see here, okay. Please complete the following questions. Whoa. Okay.
Is this a Google form?
Yeah.
Oh, jeez.
Let's do this, we can all of
Right
us
answer.
get the right answers.
Oh, optionally, go back up and see if because it says optionally, you can by opening a separate window. Maybe go in and do it, and that way you can just probably verbally do it, maybe? That's us. Yeah, and you can kind of.
Let's do this.
Okay, I'll have to submit, okay. Okay, here we go. I'll do myself with 3 N's. Correct? Okay. Public health's primary prevention aims to provide treatment and medication to individuals with the disease, keep an injury from becoming more severe, or prevent disease or injury before it ever occurs.
C.
Yep. Which of the following responses describes public health? Promotes and protects the health of people and communities in which they live, learn, work, and play. Prevents epidemic and the spread of disease, protects against environmental hazards, and prevents injury. Conducts health education programs to encourage healthy behaviors. Formulates and implements policies in order to improve the quality of health in the community.
Hey,
Great job.
Telegraphing.
Which of the following statements are true about public health directors? Select 4 correct answers. They can hire, promote, and fire public health staff. True or false?
Yes, oh, wait, yes,
We can
directors,
just try.
yes.
Okay, public health directors exercise all legal power, such as the closure of schools or businesses.
No.
Yeah, they can,
They can be a local board of health member.
no,
Public health directors call board meetings to order.
you can,
No.
but you don't.
They enforce public health laws, including rules propagated by the State Board of Health and other Title I boards and commissions.
Yes.
Public health directors issue orders during a public health
Yes.
emergency.
Do you think we got that
I
right?
think so. Local board of health responsibilities include which of the following? Select all. Selecting a public health director. True or false?
True.
Submitting the minimum qualifications form for the public health director to CDPHE.
True.
To provide, equip, and maintain suitable offices and all necessary facilities.
True.
Act as an advisory capacity to the public health director. Hold hearings, administer oaths, and subpoena witnesses.
Subpoena.
Subpoena. Write a public health improvement plan.
Yes.
Do you write it?
No.
Do you approve it?
Yeah.
Okay. Colorado has core public health services that include foundational capabilities and foundational services. These are intended to be available. Which of the following are part of the Colorado Core Public Health Services?
Andy, do it.
Assessment and planning, true or false?
Core, yes.
Emergency preparedness and response.
Yes,
Health equity and social determinants of health.
yes,
Chronic disease, injury prevention, and behavioral health promotion.
no. Yes,
Environmental public health.
yes,
Maternal, child, adolescent, and family health.
yes.
Yes, Andy.
The final knowledge check section provides an opportunity for you to apply your learning to your own situation. Board of Health answers to the following questions will help form the basis for discussion at upcoming Board of Health meetings. Are you familiar with the Board of Health Pocket Guide?
Yes.
Check out the section State Statutes of Interest to Boards of Health located near the end of the guide. Choose and read one of the statutes. Describe how or if it might be helpful to your work with your community.
Which part did we?
Page 11.
Thank you.
Okay, check it out. Choose and read one of the statutes.
And then we're going to describe how it might be, how or if it might be helpful to our work with our community.
Matt, you wanna choose one?
How about the Food Protection Cash Fund and creation?
Oh, like,
In Andy's, interested in Andy's,
Food Protection Cash Fund creation.
25-4-1608.
Would that be like SNAP? PICPA?
You gotta look it up and discuss it?
Let's look it up.
Alright. Should we do it on the big screen or?
Yep, sorry. So it is,
25
thank you,
-4 -1608.
food
Protection.
protection.
Cash fund.
Fees collected by the department pursuant and penalties collected shall be transmitted to the state treasurer, who shall credit them to the Food Protection Cash Fund, which fund is hereby created to the state treasury. The General Assembly shall appropriate the monies in the fund to the department for the payment of salaries and expenses necessary for the administration of this part. $43 for each fee collected by the department or a county or district board of health. Is this,
We basically, whenever someone pays their retail food license, we pay the state $43. So if a license is $195, we pay the state $43, and if a license is $485, we still pay the state $43.
And this pays for itself?
The general, it goes
Pays
to the
for
General
staff.
Assembly to pay for administering this.
Administering this or
Food
this?
protection.
So for the food protection, we work really closely with the state, and we also use their software, and so they kind of administer the program on a high level, and then we administer it on a local
Could you
level.
give me an example of food protection?
Restaurant inspections,
oh, I see.
Okay. Food recalls?
yeah, food recalls, foodborne illness investigations,
Okay.
foodborne illness complaints, restaurant complaints, all those types of things.
okay, so,
People who complain are really expensive.
What?
People who complain are really expensive.
Well, they're like,
Sometimes though, it really does uncover some large issues,
Yeah,
I will say.
good point.
I'm grateful for a lot of the complaints we've gotten, because then if we go there once a year, right, and the issue isn't happening when we're there, then we don't know, but when someone calls and tells you they're seeing mice running around somewhere, and then you go there and find an infestation, it's pretty valuable.
yeah, people do a really good job cleaning up when inspectors are coming, and then it's not necessarily what's actually going on the day to day.
Well,
there's
do
like a
surprise inspections?
We do it, surprise
Okay.
inspections, yes.
Pop quiz. That's
Yeah.
like what a
Yeah.
inspection feels
It's like you
when
should be
you're in
ready
the
for a
kitchen.
health inspection any day.
Mhm.
But they are not.
No.
I've spent enough years in a commercial kitchen to
Mhm.
not wanna ever eat out anymore, really.
Is there some kind of public rating system?
So all the inspections are publicly available and
Okay.
yes, there's like a very specific system, there's things you rate them on. And then there's pervasiveness, so like if you see a violation, but you're like, oh, that's really not that risky, you rate things as low, medium, or high. And then there's a point scale attached. And then if you're over 50 points, we have to go back and do a re-inspection. If you're at 110 points, we close you until you can get it together enough to not be a risk to the public. And if you're under 50 points, you pass and we stay on the routine schedule.
And those are all available to the public
Yeah, on the state website,
on the state website?
yeah, and I think it's just the most recent inspection.
Okay.
I've never gotten less than a 10.
Can confirm.
Could not get to a 0.
The remainder of the fee shall be retained by the county or district board of health for deposit in the appropriate county or district public health. So what do you guys do you wanna read more?
No, now we
No,
have to
let's-
discuss, right?
Yeah,
Discuss.
describe how or if it might be helpful to your work with your community in a succinct way. What should I put?
It will keep foodborne illnesses out of our commercial kitchens.
Ta-da!
It also helps
By funding.
fund the program so that it's not an unfunded mandate.
Go team. 50 out of 50.
What?
Alright, go team.
Okay,
Okay, so now,
I'd like a certificate.
in resources, we don't need to review, we did very.
We could make you all some
Okay.
certificates if this doesn't produce.
Okay,
When is our our first meeting, or is this our first meeting? Oh, good,
yeah, getting it out of the way.
okay.
Okay, our next
so
one.
this isn't a work session, this is technically a Board of Health meeting.
No, this is the training, no,
The training, so it's not a board health meeting.
no.
So then we'll have to meet again,
Many times.
like I was saying.
That's why Chris is here.
Keeping me
No.
in line.
That's not what's happening.
I have will you take the lead on this for a minute, so I can feed this baby?
Alright, do you guys like the reading out loud or do we wanna do some independent reading? How's everybody feeling?
I think your reading's good.
Okay.
Andy, do you wanna read quietly to yourself?
That's okay, I mean, whatever everyone's up for, I just.
I'm also happy to read out loud and pass down the line if anyone who's excited about it.
Elsa likes to
I
read.
really enjoy reading out loud.
Do you wanna go first?
Sure, yeah,
Great.
okay, thanks.
We'll help you with the difficult ones.
Same.
Yeah.
Thank you, it is embarrassing when you don't know.
I know, you're so good, I can see that. Okay, this course provides an introduction to public health and emergency preparedness and response concepts related to Colorado Board of Health members' roles and responsibility. This training is designed as an overview of this topic for local and state Board of Health members as part, okay, yes, this training is a training.
We got it. Does anyone have accessibility concerns at this time?
No.
No, ma'am.
Great. Objectives.
Describe the board's role and how they fit into a larger public health response before, during, and after a public health emergency, as established by Colorado's core public health services. Outline state and local supports for boards in an emergency. Describe tools and plans to have in place before an emergency occurs in your community. Colorado's governmental public health system, in coordination with federal, state, and local agencies, and public and private sector partners, will have the capability and capacity to prepare for, respond to, and recover from emergencies with health, environmental, and medical impacts. The Colorado State Board of Health has established by rule the core public health services that each county and district public health agency must provide or ensure, as well as establish minimum quality standards for those public health services. Foundational capabilities, which are the cross-cutting capabilities and expertise needed to support foundational services in any public health program. Emergency preparedness and response is one of the foundational capabilities. We know. Oh my
Like, you're
god.
there again, do you guys recognize
Oh,
this?
hey, hold on,
What?
I wanna see these. Just kidding.
Oh my lord.
Okay.
Emergency preparedness and response. At times, elected and appointed officials provide direction and guidance to constituents during an incident, but their day-to-day activities do not focus on emergency management and response. As part of Colorado's core public health services model, emergency preparedness and response responsibilities for all public health departments includes 4 component parts described below. Emergency support function 8 and community preparedness.
What's the 8?
So there's,
It's
is there
EOM.
16 different ones? There's different emergency service functions and they're kind of just in each category, so that the groups who are working together are working
Got it.
collectively.
What are we? Which number are we? I think we're 3 or 4. We're gonna learn about that.
I don't know what
Claire.
number you guys are.
Yeah, okay.
We're number 8.
Okay. Develop, exercise, maintain, and use public health preparedness and response strategies and plans in accordance with established guidelines and the United States Department of Health and Human Services. Develop and maintain and execute a continuity of operations plan that includes access to financial resources for emergency response and recovery operations. Establish plans to reach all persons within our communities through multiple communication methods before, during, and after incidents using the inclusive Federal Emergency Management Agency, or FEMA, whole community approach. Assure the inclusion of functional and operational considerations to enhance community inclusion for all genders, races, religions, abilities, socioeconomic status, and health status before, during, and after the incident. Plan, make plan.
Alright, nice.
Issue public health orders and coordinate with partner agencies to enforce orders. Maintain ability to provide essential and core public health laboratory testing and reporting functioning as a laboratory response network. For biological threats, operate as a biological reference laboratory. For chemical threats, operate as a chemical reference laboratory at all levels designated by the Centers for Disease Control and Prevention. Monitor the burden on the public health and medical system utilizing epidemiology to identify the problem, agent, and transmission route. Collect data and implement control measures to prevent additional transmission of illness.
A lot of these things we rely on CDPHE for.
Well, and like if we were taking this, 5 years ago, we'd be like, what? Emergency support function is the grouping of governmental and certain private sector capabilities into an organizational structure to provide support, resources, program implementation, and services that are most likely to be needed, save lives, protect property and the environment, restore essential services and critical infrastructure, and help victims and communities return to normal following domestic incidents. Public health departments are charged with serving as emergency support function 8, public health and medical, and/or a public health response for the county, region, jurisdiction, and state. Finally, establish and promote basic ongoing community preparedness, readiness, and resilience by educating, communicating to, and encouraging the public to take necessary action before, during, and after an incident. You can train more if you're interested.
I think we can skip that for now. Okay. Elected and appointed officials are responsible for ensuring the public safety and welfare of the people of that jurisdiction. Specifically, these officials provide strategic guidance and resources during preparedness, response, and recovery efforts. Next, you will hear from some current Board of Health members describing the role they and their boards play in emergency management and response efforts. You will also hear about the state and federal structures that guide response efforts on the local level, such as ESF8 and Emergency Operations Centers, EOC. Eagle County Board of Health's role in emergency management.
In an emergency response, realistically, the normal hierarchy changed quite extensively. And so realistically, what we'll end up getting from a lot of our Board of Health members or our Board of County Commissioners is policy direction, but they're not necessarily overseeing all the actions. They just want to make sure that we have the resources. So I think that's always an important starting point, is that the hat that you wear in any emergency is going to look a little bit different than a day-to-day.
You know, at the highest level, our role is making sure that resources are available. So the sheriff's office has ability to spend up to a certain level, the county manager has the ability to spend up to a certain level. That can get consumed really quickly if you have a big emergency going on, like a wildfire. So the county commissioners have to be available to make those policy decisions, to make resources available, to say, yes, bring in the planes, bring in the resources that we need to keep our community safe.
And then I think probably similar to most other counties is emergency management is not necessarily within the public health and environment team. It serves as, or sits as its own department. So I just want to clarify that we work very closely then with our emergency manager. But then our role more specifically in some of those response requirements is going to be that emergency support function 8, also known as health and medical services. And so what that means is that in any emergency, if there's going to be a threat to the ability to meet the needs of the community for our health and medical partners, then we are working with them to plan in advance of some of those concerns and try to make sure that we have enough resources. We also serve as the conduit for the communication. So in any long-term emergency, we're providing that information to those health and medical partners on a routine basis, making sure again that their facilities can be staffed, that they're accessible to the public if necessary, and other things that that some of those health partners might need.
Great. Another role I did want to mention of the Board of County Commissioners is the formal declaration of an emergency. That's a critical piece. So when you've been advised by your teams that this is an emergency that is going to exceed the resources of the county, both personnel, skills and abilities, and dollars, there is a requirement to declare a state of emergency. That has to be done within a certain time frame, can be signed by someone other than the full board, but then has to be ratified by the full board within a certain number of days. So knowing what those roles are, how to declare that state of emergency, it's going to affect the reimbursement you can get from the state, from FEMA, from the wildfire teams, from whoever is in helping you manage that emergency.
You know, one important consideration with any emergency response is also identifying the lessons learned. So a lot of times it's called an after action report or a debrief. And so one thing that I wanted to share relative to a fire that actually preceded my arrival here is our ability to communicate to our primary Spanish speaking community members was really challenged. And so that was identified as a need at that point in time. We were able to rise to that challenge, but it came up then very clearly as an after action report item that we wanted to work on. And I can say, at least that now it is something that is very clearly articulated in our response plans so that we have translation, interpretation, and communication channels that are going to reach all of our community members in the event of an emergency. So always important to learn from the prior responses.
Such a good point. I think in addition to those positives, we learned like building relationships. That was a big one, and we thought we had capabilities to communicate with our Spanish-speaking population because we did translation after the fact at websites, but we did not have real-time interpretation. We didn't have people who could communicate with Spanish-speaking communities on the spot. So it did create some real challenges for us, and I think we're much better positioned now. When COVID hit, we had real-time interpretations. When we had the Grizzly Creek fire, we had a team who came and had a different channel that was able to do real-time Spanish language version of what the fire managers were saying in English. So huge jump in our capabilities and ability to serve the community.
Yeah, so hopefully what you're hearing is not only a lot of time and energy that goes into preparing as well as response, but you need to look at things in advance of that emergency to be able to meet the needs of your community. So definitely a complex situation, but one that our Board of Health and our Board of County Commissioners are always able to rise to the challenge.
those unless anybody's deeply interested.
I've been on the Board of Health here in Larimer County for the last 7 years, which gave me the opportunity to participate in the COVID pandemic. The board does have a clear role in my mind in emergency situations. It's the department and the county's role to respond to emergencies and to have a good emergency preparedness plan. And the board needs to make sure that that plan is robust. But in the moment of an emergency, we need to be there to listen for cognitive dissonance, to be a sounding board for the director and for the health department, and to give feedback on what we hear. Emergency response has the potential to be incredibly stressful, and during COVID, it was stressful at a level that most communities have never experienced before.
From an operational aspect, most health departments have a public health emergency response coordinator and trainer as well. We do here at Larimer County, and their role is making sure all hazard preparedness plan is up to date. We're working with all of our partners, including EMS, the hospitals, our county office of emergency management, et cetera, that those plans are updated and we know each other's role. We serve as Emergency Service Function 8 lead, so that's public health and hospitals. So we're routinely exercising, making sure we're testing our plans.
This county unfortunately has had the opportunity to respond to a number of serious emergencies over the years, and in the time that I've been on the board, we've had major fires, we've had the COVID pandemic, we've had major floods. A number of years ago, there was a large influenza outbreak. A number of years ago, there was a large meningitis outbreak at the local university. The response of the public health department in that situation is incredibly important, and it's our job as board members to help make sure that the department and the county as a whole is learning from those experiences and changing our policy to reflect what we learned.
And I'd say another big policy part for the Board of Health is funding. So when you get into an emergency, there's costs, and those costs can rack up. And so that's my job to come to the board and request additional funding through the Board of Health fund balance that we have set aside for emergencies, and get their approval to utilize that funding for whatever activity it is to mitigate the response. Coordination with other agencies during emergency that's key, and that's all ran through our county Office of Emergency Center, the EOC, the Emergency Operations Center. And really, that requires those relationships prior, really requires testing and exercising your plans to make sure you've thought through all those processes. So that's something our team is doing daily. That's something that's ongoing and must be done well in advance of any emergency.
Yeah, I want to add to this, and I think this is really important. And this is where the board members have a role. We need to be pushing our departments to make sure that they're having those relationships outside of the emergency process. Those relationships allow people when they're stressed to communicate with knowledge of each other. High-functioning teams know how to communicate during times of low stress. And then they practice that communication frequently. And so an example of that is health and health policies, and it's one of the reasons why that's so important. When we sit at the table with transportation, when there's an emergency and we need to engage the transportation system in that discussion, we have the relationships to be able to do that. It's very much part of the thought process of being a board member in this situation is to think about how do you make sure that your department is building those relationships? And those are questions that we can ask. From a board perspective, a healthy community is a community that has connection. And I think that it's very important that we work to make sure in our communities that those connections are healthy, so that in periods of stress, we're not fighting each other, but working together.
That was lovely and articulate.
That was nice.
That was nice, yeah.
And just so you all know, we hold bi-monthly ESFA meetings to work with our community partners in all of those areas, so we know each other and have those relationships. Alright, 4 steps you can take today to ensure your Board of Health is informed. Review your county's emergency plan. If you don't have access to that plan, reach out to Claire. Schedule time for your emergency manager to attend a Board of Health meeting. Well, you can invite Claire to the first one. Request a high-level presentation about partnerships your agency has with other community agencies and organizations. We'd be happy to answer, put together a presentation or answer any questions. And reach out to your emergency manager to ask about opportunities to participate in emergency management.
I think we're gonna have, well, I don't know. Oh, Tim and Lauren are on. Don't we have a meeting with Claire to discuss our role in the OEM, you know?
Yeah, we, later in March, we have the meeting with Claire and then the State Division of Homeland Security and Emergency Management, which will walk through, like, give you a broad overview of all the ESFs, but then what the policy group, or AKA the executive group, which is the board and this manager and attorney.
Great. Thank you.
Claire can also come to a public health meeting, but she works very closely with Kelsey and Julia.
All the time, every day.
Yeah.
Alright, ESF shown in the diagram below is a grouping of governmental and certain private sector capabilities into an organizational structure to provide support, resources, program implementation, and services that are most likely needed to save lives, protect property and the environment, restore essential services and critical infrastructure, and help victims and communities return to normal following domestic incidences. So this is the 15 emergency support functions. ESF 8 is one of Colorado's core public health services that all local public health agencies are responsible for providing. You can also refer to the core public health services website. Within the Colorado Core Public Health Services, the State Board of Health has established 4 main responsibilities for all health departments as a part of ESF 8. 1, maintain written procedures for ESF 8, which can include county comprehensive emergency management program, emergency operations plan, and or a public health response plan. Just so you all know, we are writing a public health emergency operations plan right now. 2, develop, train, and exercise a decision-making protocol to support agency leadership in making policy-level decisions during a public health incident. 3, develop and maintain strategic partnerships with local agencies, nonprofits, private sector, healthcare organizations, state agencies, and associations to support public health mitigation, preparedness, response, recovery, and resilience efforts. 4, define roles and responsibility of your local public health agency in establishing short and long-term community recovery goals. ESF 8 functions. More broadly, ESF 8 provides the mechanism for coordinated federal assistance to supplement state, tribal, and local resources in response to the following core functional areas. How do we feel about reading these independently? Okay. I think the main takeaway here is this is pretty broad and it's not all things that we do on like our local programmatic level, so this is why those relationships are really important. And then in an emergency, we have access to different resources than say like St. Vincent would.
Yeah.
So if they're having issues with these things, we can be like a link to those resources basically. Alright. CDPHE is the lead ESF 8 agency in Colorado. CDPHE serves as a key advisor for public health and medical EPR efforts across the state. Additionally, in Colorado, most local public health agencies are the ESF 8 lead in their communities. However, it is important to check in with local emergency managers to confirm how ESFs are structured within different local communities. When reviewing the history of public health in Colorado, it is interesting to note how many public health activities were founded upon emergency preparedness principles. Colorado has a long legacy of addressing large-scale public and environmental health emergency events. The following state agencies offer resources, training, grants in relation to ESF 8. So DHSEM, Department of Homeland Security and Emergency Management. Claire works with them really closely, and then we also have a link to them, if we need to, but the field manager she works with works for DHSEM. The field manager that we work with works for CDPHE. OEPR, which is a part of CDPHE, that's where our field manager comes into play. Alright, a resilient community is one that can adapt to changing conditions and withstand and rapidly recover from disruption due to emergencies. While the previous sections of this training have dealt with state and local levels, preparedness must take place at all levels: federal government, state, tribal, and territorial governments, private entities and non-governmental organizations, local governments, and individuals and families. Within the Colorado Core Public Health Services, the State Board of Health has established just one main responsibility for all health departments as part of community preparedness. 1, establish and promote basic ongoing community preparedness, readiness, and resilience by educating, communicating to, and encouraging the public to take necessary action before, during, and after an incident. As a Board of Health member, you can play an important role in promoting community preparedness. One example of a preparedness task that boards can engage in is helping to coordinate and disseminate local family or community preparedness campaigns and information. Informing your community using already available materials. For many local public health departments in Colorado, a practical option is to provide links via a webpage and or social media to messages and information created by national organizations. We do this. Below are 2 examples of a family preparedness public service announcement from FEMA.
When it comes to making plans, you are the best. Those 9 months were also 273 days of planning. What about your daughter's first costume party? It was out of this world. And let's not forget those barbecues you plan in detail for your family and your more vegetarian by the day best friends. That surprise party for your parents' golden anniversary? You get the golden planning. The same way you plan each detail for those moments, start planning to protect you and your loved ones from a natural disaster. Sign up for local weather and emergency alerts. Prepare an emergency kit and make a family communications plan. Protecting your family is the best plan you can make.
Disasters can happen anytime, anywhere. Wherever you are, the FEMA app is there. It can help you plan. It can help you protect. It can help you recover. Take charge of disasters with the FEMA app. Download it today.
In addition to providing online materials, several organizations also host programs to help citizens prepare. Use the arrows to see several Colorado examples of these types of programs. For more information, please follow the links. Dare to prepare. It's back. It's back. It's different. CERT, Community Emergency Response Team. Alright. Alright, additional state resources. The Colorado Resiliency Office Department of Local Affairs. Office of Emergency Preparedness and Response. Again, that's our CDPHE contact. Alright. Knowledge check. Okay. Quiz. Gosh. Bring it. Got there fast. Is that right? You? Oh, okay. What are 4 steps you can take today to ensure your board is informed, aware, and prepared to take action in an emergency? Schedule time for your emergency manager to attend a Board of Health meeting and review your county's plans, or for the board to visit the emergency management facilities and staff in your county. Yes, great. Have confidence that you'll be able to handle situations as they arise.
Yeah.
Trap. Well,
That's the thing you should definitely prepare yourself for.
but I think they're saying in B that you're just gonna assume
Just
that
man.
you'll be able to, yeah.
I know, but I'm just saying grammatically that was poorly written.
Confidence is a vital component
Of leadership, yeah. Fine.
Well, let's read all of them and then we
Yeah.
can determine.
Yeah.
Encourage your health department to create partnerships on a variety of issues with other agencies, organizations, and groups. Yes or no?
Yes.
Learn more about the county's emergency preparedness and response plans for individuals, families, and communities.
Yes.
Great. Ask about opportunities to participate in an emergency management exercise.
Yeah.
I don't disagree with you, Elsa.
Yeah, I know, it's okay.
True or false? Elected and appointed officials are responsible for ensuring the public safety and welfare of the people of that jurisdiction.
True.
Yes. The lead emergency support function aid agency in Colorado is CDPHE or local public health agency
B.
in Colorado.
Oh, in
okay.
Colorado, yes, not in Lake County.
Thank you.
Discussion question. The final knowledge check section provides the opportunity for you to apply your learning to your own situation. Reflect on the relationships you and the other board members have or plan to build with key community partners. Answer the following questions will form the basis for discussion at upcoming Board of Health office hour meetings. Okay, so in an emergency response situation, name some organizations in your community it would be important to partner with. Do you or other board members know people from these organizations? How will you continue to build these partnerships?
Let's see, the sheriff's office, the fire department.
Search and rescue.
Oh, good one.
The hospital.
Yeah.
EMS?
Are there any
What's the
nonprofits?
911 emergency,
Elsie Beck.
the communications 911 emergency?
Dispatch.
Oh yeah,
E911?
E911.
E911.
School district perhaps?
Good one.
Yes.
Lidres. LIDERES.
Thank you.
Capitalize that, since it's not showing it as a, like, that's a group that, I would capitalize it.
Oh, got
So they know it's an organization.
What about the city administrator?
That's a
City,
good
yes.
call, man.
City limit.
Elsie Beck.
About the Office of Emergency Management.
Yeah, I was gonna say, it's like, same as emergency services.
Well, I guess in emergency service, I meant EMS, like the ambulance services, as opposed to Office of Emergency Management, meaning Claire.
The advocates.
Also encourage like St. George, I think if we needed to feed
George.
people, yeah.
St. Drug.
I mean, as a,
Center.
depending on the emergency, as our sole food source, is there something you would like?
Safeway?
Yes.
Yeah, that's a great point. CDOT?
The liquor
Still
store, we're gonna need.
I think they do okay.
Well, and we've got a few.
We're missing
I mean, who
maybe.
do we not need in emergency?
Yeah.
In an emergency, we all need each other. I think we could really blow this up, blow this list up.
Yeah. Sol Vista,
Mhm.
Yeah.
they come to our ESF8 meetings.
Nice.
CMC?
Yes.
Think.
It's gonna be a crowded room.
Sure is, that's why we're all divided up, right? All these
Takes a
different
village.
organizations, I think, go into different ESF8 functions and then we all lead them in different ways.
Parkville.
Oh, yes.
Oh,
Maybe level
snap.
sanitation.
Sanitation.
Man.
The forest. district.
Or service.
Yeah.
Or service.
Wildfires, yeah.
Who do we, I mean, honestly, we could
yeah,
just be.
I think we got it.
Yeah, okay.
How will you, do you know people from these organizations and how will you continue to build these partnerships?
Or more, are there any organizations that here that we don't feel like we have? I feel like,
Safeway.
yeah, that we don't have
Yeah.
a good point of contact.
Right.
I mean, I know Laura, but I wouldn't say as a county commissioner to be like, hey.
Mm-hmm.
So Safeway, I think, is the one on that.
And how are you going to build that partnership?
I guess I would start with the Food Access Coalition to see if they already have a relationship with Safeway. And then make sure that, well, and that's, since that's part of LC BAG, that would be like, cool, at least this group has relationship
Might even
and connection.
pay to bypass local Safeway and go straight to their corporate offices
Yeah.
to find out what other communities do in these kind of situations where it's the only.
Yeah, good idea.
Do we feel good?
I still think the liquor store should.
The liquor store.
Put it on.
I'm kidding.
I'll do whatever you want, I don't
Well, I
care.
mean,
Liquor
it
store, I
is
guess we
interesting
better
when
put ours
you
on there,
think
too.
back to
COVID,
COVID
mhm.
and businesses were needing to close and keeping the liquor store open so that people don't end up going through withdrawal.
Yeah, that
And
was,
ending up in the hospital is a real,
that was serious.
And the weed
coordinate.
stores, were the weed stores open too?
I think so, yeah.
Yeah,
They were allowed retail to stay open in a certain way.
I mean, but that's like the thing, is like, how do you allow certain businesses that people are physically dependent on to operate in a safe way in that event? It's like a pandemic or even, yeah, I mean, if you have a wildfire or, I don't know. Yeah, these are things to really be thinking about, because you can die from alcohol withdrawal pretty quickly.
Right.
Really?
We could say, like big business advocacy groups on there. Like the chamber.
And strong alcohol is also handy in a field surgery situation.
Little for you.
I'm putting it on here.
Yeah,
Great, we should probably move on just because
Yep.
to stay on.
But I think this is
That's
it.
great.
it might be the most comprehensive list this test has ever.
30 out of 30, the group is absolutely crushing it.
Oh god, can't wait.
Okay.
Okay. We have to answer that question.
No, that was the
Scroll
same
up.
form.
Oh, okay.
Summary research.
Alright, a summary, we already went through these things, does anyone feel a need to review any of these or have any outstanding questions?
Still pretty fresh.
Thank you,
I see a thank you.
thank you for completing this course. Great. Okay,
Wait, let me get us back.
What did you do?
One more, hopefully, I think it's just.
there it is, yeah.
Great job, thanks for doing this.
And that's perfect, cause Kelsey is our public health emergency preparedness and response point person, so. Okay, let's see, this is all the same thing.
Somehow I don't think the CDPHE site is open anymore.
I know. It's okay, we'll just. It's a.
Yeah, 80.
We can send a certificate. We can send a certificate.
And Julie, do you just kind of report that they all did that and then?
Yeah, I'll talk about that in a sec, here we go.
Okay. Alright, we have to do the feedback.
We need Ken Burns to narrate some of the videos at a higher volume.
Mm-hmm.
Okay, 10 minutes, the survey. See, I like that it opened in a new one and didn't.
Yeah,
There you go.
that is better.
So if you feel like you need to go at any point,
Probably good.
I think I'm gonna put everyone in here again, right?
Yeah, under the full name.
Let me see, I wanna make sure I don't mess this up. Okay, so make sure everyone receives credit for completion. Please ask every participant to complete this survey
Oh,
to register okay, see, here you go.
okay, scan the
That was in the
QR
back of
code.
my head. Yep. Let's see how it works.
Thanks for joining us on this journey.
Did you learn anything new, Chris?
Me?
Did you learn anything new?
Yes, I learned that our new commissioners are great at paying attention and engaging with the information
Yeah, which we
presented as they've
appreciate.
been for the
Yeah.
last 3 weeks and
As we text our phones.
I need to pick my phone up, except it twice to look up definitions of
Did it work? Yeah, perfect.
strange words I didn't.
But I also expanded my vocabulary.
Yes, yes, there we go. Bonus, that
Apparently
was
there's
actually
options to be a public health agency.
Duplicity.
Yeah,
In your role?
Yeah,
Oh yeah, you're like county public health agency. That's who you're affiliated with.
not Board of Health. We're just
Just your
affiliated.
affiliation, yeah. Yeah, so you'll, yeah, that's a great point. And then you have the next thing is
What's
your
your
role.
role? Oh, yeah, yeah.
And we did our board took the training together using co-train facilitated by our executive director option.
Cool.
So as you guys are filling this out, let me know if you're, but this is, you have to do this to get your certificate to say that you completed it.
Thank you all. See you in a
Thank you,
Thanks,
Kelsey.
Kelsey. See you soon.
Chris,
yes, ma'am.
have we technically been sworn in as Board of Health members?
That is the appointment aspect of it, is that yes, since the
Since
by code, y'all serve as the Board of Health based on the size of the county and stuff.
So our
You're swearing
swearing
in.
in date is the same date?
as
Okay.
that, yes.
Thank you.
So helpful having you here. I'd have been like,
I would have just guessed.
yes.
I'm gonna hang this on my wall. Did we use Co-Train?
Yes. And so you're the option that we did it all together, I think it was option number 2, that we did it
Our
all
board- Our
together.
board took the training together using Co-Train facilitated by executive
Correct,
director.
exactly.
do you guys have a separate Google account for your county email address? I need to set that up. Worker business. business ever go home? Yes.
Yes.
County code out there.
And so next year, there's like different options, I did all of the more like intro orientation ones, but next year we can mix them up a little bit, instead of doing like a public health orientation, we could do public health policy development, and we could do some ones that are a little more advanced as we become more advanced.
We just did the orientation?
Yeah.
We didn't talk about legal authority or oversight, even though we did? Those are separate trainings?
Yeah, so we did the public health orientation, cause if you look, legal authority and oversight were other ones we could have done.
Okay.
And we did the board's role in emergency preparedness and response. So we did public health orientation.
It said that was only an hour.
Yeah.
Wrong.
Yeah, maybe if you do it alone and you don't
And you
really
read it
do,
instead of listen-
yeah, or
instead of
something,
listening?
I know,
No.
I'm kind of surprised, right?
You're putting
They
out
were,
feedback.
yeah, I gave this amount of time to offer a lot of buffer and discussion, and this is like what it took for us to just do it. But I think it is slower when you do it as a group, cause we did do some discussion during, which makes sense, it's hard to kind of hold your questions till after.
We also skipped a lot.
Did you?
What? Oh no, it's cause your business has to, I got it through, I think Outlook when I did it. You can
This
just
was one of
use
my
your
like questions for Liz.
Yeah,
Yeah.
I can't remember, it was convoluted, it definitely took me a long time to set it up.
Okay. So here's my Gmail. Alright.
Okay, do you want to call an end to this?
Yes, it is 11:51 a.m. Tuesday, February 11th. And we will end this work session of the Lake County Board of County Commissioners. Thank you, everyone.
Thank you.
Thank you, Julia.
Yep,
Thank you, Julia.
can we stop recording?